Ladies and gentlemen, it's Riccardo Bertolo speaking. I'm working in Verona. I'm associate editor of the UROONCO platform Kidney Cancer. Today I have the pleasure to have with us Dr. Pieter De Backer. He is a surgical artificial intelligence lead at the ORC Innotech, which is kind of a spin-off section of the ORC Academy in Belgium, dedicated to bridging the technology gap from biomedical engineers to surgery. You know, today we have a very technological surgery, and particularly in robotic surgery for kidney cancer. It's important to underline that Dr. De Backer had a kind of a parallelism between his current position and job and all the education he had. He became first an engineer, hyper-specialized in biomedical engineers and microelectronics, and afterwards he graduated in medicine. He became a urologist, and now we are colleagues. So Peter, we were very impressed by your talks here at the EAU, dedicated obviously to auxiliary technologies and the application of real-time artificial intelligence. So among all the application I was looking at, there is the one that become with artificial intelligence able to detect the surgical scene and understand which is the step of the procedure. Why are you working on this?
Yes, so first and foremost, Riccardo, thank you for the very kind introduction and for the invitation. I'm happy that we can discuss this topic. So coloring and what we call segmenting the different areas during the robotic surgery. For now, at ORC Academy, as a teaching institute, we see it as a way for medical students or junior residents to learn them a bit about robotic surgery, but indeed, as you say, it's a step towards the final goal. And what the final goal is for us is understanding the complete surgical scene. Because for us, it's really important if you want to automate surgical assessment. There's too little surgeons to train there's too little experts to train so many young surgeons, so we need some automation in that process. And to know when an error happens, when an action happens, when you should deviate. Maybe the robotics can intercept certain steps that you're taking. We already have in DV5 haptics, for instance, so we're getting there. To know that, we need to understand what is going on in the surgical scene. And this is actually one step in a very bigger project.
Yeah, because I guess sometimes even an experienced surgeon is enabled just with a frame to understand
exactly
which is the organ to be operated, etc.
And if you can get some hints there or some direction, for instance, we just started a single port program. When you orient into the psoas, going towards the kidney, all of these different things can probably help you if they can help you guide. And this is the first step towards a very bigger goal of automation, so to speak, or essentially automated surgical skill.
Thanks you. And let's talk about the use of augmented reality as a tracking during the surgery.
So, well, I know you've been very active in the field as well, testing out some technologies, and augmented reality for us is a tool that can hopefully ease the learning curve. But we all know that there's still a lot of things to be done before it can be really implemented in the clinical practice, right? But one thing that first needs to happen is we need to align continuously this. In our case, I'm specialized in the renal cancer part as well. So we need to overlap the kidney that is continuously shifting with breathing. So to do that, now we had before the engineer in the room.
3D mouse, etc.
Yeah, rotating all of that, all of it, right? So you don't want that and you don't need that, and it's not useful. Actually, it's impeding your surgery because you rather have it in the Tile Pro as a separate entity, look at what you're seeing and make the mental map. Just like you would be doing cognitive biopsies, you make the mental map. But now we have technology using AI that can track the tissue and continuously follow that kidney. So the next step is now it's static. And if the kidney, of course, we put the patient in the left flank for a multiport, and then, it's folding. We need to adapt for that folding, and this is the next step. So it's a step in the bigger direction, but it's also a step towards what we call digital twins. This is really duplicating the abdomen in a complete digital world to really understand it.
Wow. And you anticipated me informally that you are working on projecting a copilot.
Yes, true.
Tell us something about this one.
So the copilot, we tested it during our conference 4 weeks ago. Is really a type of ChatGPT, if you want, But more than that, it's a system that takes into account the real-time surgical feed, and you can ask it questions on that surgical feed. So we had a system that has read every publication of prostate cancer, all of the guidelines, all of the inventory of the robotics suite. So the technology, like a bipolar forceps can put so many force, and for this you need a force bipolar, everything it has read.
Everything?
Exactly. We put that into a system together with the video, together with this is the prostate, this is the nerve bundle, this is the bladder neck. And like that, you can, during the surgery, ask, what am I looking at? What phase am I in? How long will the surgery take? Because it has seen so many surgeries that it can predict for this case with this pathology, how long will it take? And we hope like that to disseminate knowledge so that the surgeon can be focused on the surgery, which is most important, and that all of the questions can still be asked without interrupting the surgical flow.
Well, this is very important, I guess, particularly for youngsters.
Exactly.
For
again,
beginners.
it's super crucial.
When you have a kind of an anatomical structure, you don't know.
And if we're trying to understand and support the surgeon, you need a system that knows more than just what am I seeing. It also needs to know, if I use coagulation during my nerve bundle dissection, I don't want that because this will cause impotence. And like that, you need to have more context than just seeing. You need to have context of what is good surgery in itself. And we hope to, again, put a small piece in that bigger puzzle.
Yep. And tell us, expand about the pod racing prospective trial you're running.
So you're an expert in all of the evidence on selective clamping and what we can and cannot do, right? We know that from the clock trial from Verona that actually selective clamping doesn't really matter in healthy patients for small renal masses, T1 tumors. And we know that it's difficult to quantify the effect of selective clamping. But actually we have no evidence in these patients with impaired renal function, single kidneys. It's really a niche of the population. But we believe that we can really, that it really matters to do selective clamping and that it will impact renal function in these patients. And so what we are doing now is a prospective randomized controlled trial in which we predict the clamping strategy as we've been doing retrospectively. To get that first sense of evidence, can we predict the clamping strategy? And so we compare on one hand the CT scan based clamping, and on the other hand the 3D model based clamping, where we can then tap the artery and it will tell us the part where it's going. So it's led by the University Hospital, by Charles Vapraat, and we have 5 collaborating centers, including the centers in Ghent, in Aalst. So we're all collaborating because we really need sufficient patient data and volume to show that really 3D modeling can help, and selective clamping is feasible to be trusted. So that for these impaired or frail patients, we can use it with more certainty.
Thanks, but this is very nice. It is also a matter of outcome measures, because also the Emerald trial was aborted as regarding selective clamping. So I will look forward to your results with such a dedicated technology.
It is quite a niche, but we still strongly believe in it because of that.
They are more and more because...
there's so many things known already, but we need some more evidence there.
And last, as regarding 3D reconstruction, high quality 3D reconstruction often require lots of work for segmentation, contouring, etc. Dedicated bioengineers maybe are providing this, but there are some times where you would love to have ASCAD for, but you don't have it. Exactly. You're working on an automated one. Which are the characteristics, which details will lack in this automated one with respect to the one time consuming.
So we had exactly what you're saying, right? You want a model, and we had cases where during the OR we said, okay, do we have a 3D model? No, we don't, and then it's too late to ask for it. But that's the same if you work with the companies. You need to send your CT file, your DICOM file 2 or 3 days in advance at least, and then you get it, and it's always very costful. And this is one of the reasons that I think we're lacking evidence on the value of 3D models. If it was for free, I think everybody wants to have a 3D model for every case, right? But it's not. So,
unfortunately.
Exactly, unfortunately. So what we did is we built a website in which you can drag and drop your CT scan so that it has the AI doing the automated segmentation. So in about 90 seconds, we get the 3D model. So during the case, we can make it. We did it already. I had the case with Alex Motri some time ago, and he said, Peter, we have a 3D model for this case. I said, no, but let's make it. And so the thing is that you have a 3D model that is like 95% correct.
Okay.
And if you look at it and you can compare it to the CT scan, you know, okay, maybe I'm missing that little branch or that little branch for if you want to do super selective clamping. But for the whole approach of knowing my tumor is more anterior or more a little bit more to the middle, it gives you that perfectly.
It's anyway.
And maybe we don't need that 100% correct check by the radiologist, because in the end, it's us urologists taking the decision, right?
I am convinced that most of the times, some of the details we get from the time-consuming 3D models are maybe useless. So we need something less. This is a very nice solution.
Yes. So we think that that is the future, and I would love to hear your thoughts on it very soon.
Thank you so much, Pieter.
No, thank you.
It was very nice to have your insights, your experience. You are very, very good at doing your things. So thanks for being with us and hosted in the UROONCO platform.
Thank you very much. See you.